All right, thank you all for joining us for the afternoon session. We've got two pretty entertaining pro-con debates here. Our first pairing here debate regularly in their home city of Syracuse, New York, where they team up to run the SUNY perfusion program. Our first speaker. Oh, yeah, my bad. Yeah, we're good. Yeah. What do you want? We're good. Ed Darling is associate professor at SUNY Upstate Medical University perfusion program. During most of his 35-year career, Ed has been devoted to pediatric perfusion through clinical, scholarly, and professional activities. He was the AMSEC Peds chair from 2004 to 2007, and selfishly and graciously, when he stepped off the committee, that was my opportunity to join the Peds committee. So I'm always very grateful to him for that. Ed was one of the principal architects of the Fellow of Pediatric Perfusion recognition program, and he's a fierce advocate of the pediatric perfusion subspecialty and the place that we represent in the perfusion community. Ed?
Thank you, AMSEC. Thank you, moderators. What an honor it is to be here to take part in this. And I don't know where to start, folks, because for the last 23 years, Dr. Searles and I have toiled in perfusion education in near blissful harmony. There's only been one conflict between us, just one, and it has been the nature of cardiopulmonary bypass on children. When asked the difference between adult and pediatric perfusion, Bruce will say, well, it's smaller and it's slower, and there are differences in top flow. Make no mistake about it, Bruce believes that pediatric perfusion is simply adult perfusion with smaller tubing, smaller oxygenators, smaller filters, smaller clamps. Now, we all have the rights. We all have the rights to our opinions, but what bothers me is him taking this shallow and erroneous position and indoctrinating the vulnerable. Just the other day, I logged in to the web stream in a sim lab, and this is what I saw.
Dr. Searles, when can we simulate pediatric perfusion?
What did you say? Who's filling your heads with these crazy thoughts?
Well, Professor Darling told us that pediatrics was a specialty, and I want to learn those skills.
A specialty? Really? Here, you want to be a pediatric perfusionist? Give me your clamp. I'll show you pediatric perfusion. I'm going to take your adult size clamp and I'm going to give you a pediatric clamp, because that's the only difference. In fact, here, I'll make you a neonatal perfusionist. Let's run a case like that. Now you're simulating neonatal bypass. All the skills are the same. I don't care what Professor Darling tells you. What do I tell you?
Small is not special.
That's right. I'll be in my office.
I have no words. And so I look forward to this opportunity to finally put this troubling misinformation and disinformation to rest. We will settle this right now, Bruce. Are pediatrics patients just small adults? Of course not. Of course not. Pediatric perfusion is a unique branch in our profession. There are significant differences between adult and pediatric perfusion to make the obvious statement that pediatric perfusion is a distinct subspecialty. And I'm sorry, Ron, you must feel like you're in the twilight zone. In fact, I even question if this debate is even appropriate for AMSEC, the world's most prestigious international perfusion conference. Isn't this like inviting a flat earther to speak at the American Geological Society? So in any event, I intend to provide proofs that pediatric perfusion is not just small adults, and therefore pediatric perfusion is in fact a distinct subspecialty within the perfusion profession. I'll discuss 4 lines of evidence: medical and scientific agreement, perfusion community consensus, factual technical differences, and factual anatomic and physiological differences. Point 1, medical and scientific agreement. The entire medical community has declared the truism that children are not just small adults. Every branch of medicine has pediatric attached to it in some way. And that just highlights the very obvious statement that kids are different than adults. And when we start to look at perfusion, we have to consider that as well. Even in other allied health fields, it's reverberated that clinical application between adults and pediatrics is different. Physical therapy, ultrasound, respiratory therapy, and I contend perfusion all have these pediatric subspecializations. These differences are real and factual, as we'll discuss. So the larger medical community affirms the differences, which brings us to point number 2, perfusion community consensus. Our profession itself declares that pediatric perfusion is unique, separate, and a subspecialty. We see it in our earliest of newsletters. Here in 1977, we see it. Pediatric perfusion postgraduate courses. So even early, before certification was even a thing, we identified pediatric perfusion as worthy of special conferences to discuss the very differences that Bruce is denying. Doesn't stop there. Over the years, throughout our professional literature, we've seen pediatrics discussed. Bill Harris points out that there's a balance of pediatric and adult cases is important, that skill levels are kept current in both areas, separate areas. It requires a totally different mental state to pump a child, says Pat Courtney. I'm a firm believer in the value of specializing in pediatric and infant perfusion. I've never seen any articles to the contrary. I've never, in my 37 years in this profession, heard anybody argue against this, except for him. Even our peer-reviewed literature speaks of it. In this article in 1993 by Phil Beckley and Phil Syracuse, they were discussing master's education for perfusion. Is it needed? And one of the sub-elements of this study was 58% of the AMSEC practicing perfusionists felt that there was a need to recognize areas of specialization within the field. And guess what? The #1 area was pediatrics. Even job opportunities scream pediatric perfusion is different. Otherwise, we'd just be offering jobs to perfusionists and chief perfusionists. Even social media and Reddit supports the fact but you know what really affirms the professional consensus is here right now. There are 2 tracks. We have pediatric perfusion. So the fact that Bruce is here to discuss this, in a way, you are affirming. You're tacitly consenting that this is a specialty. Let's move on. Point 3, technical differences. This is a very common graph that appears in all of our literature of chapters and book chapters of the technical differences that can exist between adult and pediatrics. And we teach this, Bruce, in our school. Temperatures, pump primes, perfusion, pressure management, blood gas management, glucose management. All of these have distinct differences between adult and pediatrics. We even have different standards and guidelines, completely separate standards and guidelines between perfusion practice and pediatric and congenital perfusion practices. And then there's so much anecdotal data I can fall back on to actually validate the idea that there are technical differences. Again, this is from Angela Naif. She interviewed dozens of pediatric perfusionists and in their capstone, these were highlighted. Pediatrics bypass requires a higher degree of sensitivity in equipment selection, drug administration, termination of bypass. It's easier to stent an infant heart during pediatric CPB. Precision is the primary difference. It comes down to fidelity, margin of error, motor skills. There's different flow rates, muff versus non-muff, pH versus alpha stat. So many, many technical differences. Point number one, anatomic and physiological differences. We know that the oxygen consumption rate is much different in the first years of life. The basal oxygen requirements, this is a very old graph from the earliest of our perfusion textbooks, but we can find modern graphs as well that show that the need for oxygen delivery is much higher. And in the morning sessions, they talked about DO2I and flow and hematocrit and these topics. And it's clear that it's a moving target in pediatrics. Metabolic rate for the adult, it's a fairly narrow bandwidth. For pediatrics, it's a moving target that you have to hit every day. Because every day, different age child, different size child, it's going to result in dramatically different compensatory mechanisms by the perfusionists. There's more than 35 known congenital heart defects. Incredibly different too. And, you know, again, Bruce, you teach an unbelievably good cardiac embryology course. And, you know, it's important, and these are very, very good for the students to learn where these missteps in the embryological development of the heart may occur, and then to how they impact us down the road. And if you can classify these as acyanotic and cyanotic, and all these differences have a direct impact on the pediatric perfusionist that's running the case. Pulmonary blood flow can be increased. Obstruction from blood flow from the ventricles. Pulmonary blood flow can be decreased. You can have mixed blood flow. All of these things in the palette of congenital heart defects and variations in anatomy really can complicate the life of the perfusionist and has to be taken into consideration. I think a respected chief perfusionist said it best, and the principal most essential difference. Oops. Oh no, I pressed that button.
Oh, nuclear button.
That's the button he's not supposed to press, right?
Thank you. The principal most essential difference between adult and pediatric cardiopulmonary bypass is variation. Numerous types of variation that exist to a much greater extent in the pediatric than adult perfusion. Variety of repairs, variety of patient size, variety of circuit size, variety of primes, volumes, pharmaceuticals, blood products. In peds, we make decisions on every single case to customize the perfusion for each patient. And so with that, I'm going to allow Bruce to present his opening statement. But I hope that I have changed your mind already and that we can end this debate right now.
Thanks, Ed. Bruce Searles is Associate Professor of Perfusion as well as the Director of the Perfusion Program at SUNY Upstate. Research interests include quantitative and qualitative outcomes of high fidelity simulation and perfusion education. Bruce aims to improve student learning and patient safety through immersive simulation-based criteria or curricula. Just on a personal note, those of you who know me, Bruce was my primary and only instructor my first year of school. So I'm honestly eternally grateful for him for my perfusion career here. And it's really an honor for me to be able to introduce him. So welcome, and
Thank you.
kind of take it easy on Ed.
Thank you, Ron. Thank you, panel. Thank you, peers and colleagues of mine whom I have the most respect for. And I would like to always help the community as much as I can. And in this regard, I think you've been sold a bill of goods. And I would like to help you see the light with regard to pediatric perfusion and whether it's special or not special, or exactly how special it is.
So we're going to try and talk then a little bit about pediatric perfusion. And we're going to address some of the points that he had. We didn't conspire with our presentation at all. So all these are my thoughts as they roll out. But I did hear him saying while we were talking that the primary difference, well, I'm sorry, was that you know, this all started in 1977. To which I'm like, really? So some hippie in 1977 says something, and we just repeat it over and over and over again. This reminded me of a book that was recommended by our administration called The Contrarian's Guide to Leadership, Thinking Gray and Free. And there were 2 chapters in this book that are relevant to our discussion today. And in chapter 3, it's called Experts, Saviors, and Charlatans. And in the book, the author quotes another author, and whose quote is, "A leader should pay close attention to experts, but never take them too seriously and never trust them completely." And I think that may have been what happened in 1977. Somebody who had a very high standing in the community wanted to have a meeting with only 15 of his friends, and they put together a conference, and they got together, they drank a lot of beer, and he went off about how special things were. And since then, it's just been passed on from generation to generation. So I come here today to challenge that position so that we can challenge the status quo, so that we can think gray and free. Don't be constrained by just what your mentors told you, but think for yourself about the situation. So that brings us to chapter 4. And in chapter 4, it is called "You Are What You Read." And in this book, in this chapter, the quote that stuck out the most was, "For most people, reading is an insidious means by which they lose their intellectual independence. Something is told to you, and you believe, well, this person must know better than me, so I can just stop thinking about that myself. And I'll try to mimic them, and I'll appear smart myself by telling somebody else this, like I am doing with you in this book." So it appears that perhaps pediatric perfusion is way different. Just pass that down. I'll tell him, he'll tell you, you'll get to Ed. Next thing you know, Ed's up here defending the position with all of his spirit. For a moment, I would like to appease Mr. Darling and consider, like, what if perfusion actually, pediatric perfusion actually is a specialty? Wouldn't then that make adult perfusion the other specialty? Would there be 2 specialties in this? Because if they're so drastically different that one is special from the other one is special from that one too. So maybe, I guess, perhaps we could discuss there being 2 specialties. So, but what would make it a specialty? Is the declaration a specialty based on the volume of cases? There's a whole lot fewer pediatrics, that's for sure. That's a mathematical fact. Does that make it special because there's few of them? Is there a unique skill set or techniques? Are there unique technologies? Is there physical equipment that you use that the other perfusionists don't use? Is the diversity of pathology and physiology considerations, is that what makes pediatric perfusion a specialty? How about precision? I saw the word precision on some of his slides. The things are more sensitive. So we'll dig into that a little bit as well. So what the question overall for my position is, I don't really have to defeat his position, because I'm going to offer him the opportunity to provide evidence that there is a specialty. And I would ask, what would warrant identifying pediatric perfusionists as a specialty? But first, before you think that I came here to dash your fear, your self-image and tell you that you're not special, I'm absolutely not going to do that. In fact, I am here to tell you that perfusion is the specialty. We are the most elite healthcare special forces team in the entire medical industry. So this is when I became most aware of that. Standing at a bedside with our chief of surgery, Dr. Fink. We have a patient on ECMO, desperately needs dialysis. We've called the renal people. They don't have any dialysis machines that are not taking care of other patient, but we're not going to let this patient die. So what was his solution? We're not going to let a patient die, so he calls a perfusionist. And he and I talk about that. And then he brings the nephrologist to the bedside and he introduces me, says, "This is Bruce. He's my perfusionist. He can do anything." And then he left, leaving me with a nephrologist who knew at this point that the hierarchy in the room at this moment was he was below me. And we were going to work this out. I explained to him how I was gonna use a couple of roller head pumps and a Mintec pressure box to build a dialysis machine so we could save this patient's life today. That's how perfusionists are viewed. We're the special forces. When it has to get done, they call us. We're the most elite. We stop people from dying. We introduce life into situations where there would certainly be death. You stay alive when your heart is stopped. You stay alive when you don't breathe for days. Why? Because we have the skill set. We, you, he, I, these people here, not that guy there, but everybody else in the room has the ability to do this. And it's a special skill, and it's a skill that we have that the rest of the medical community knows about, but they don't have it themselves. So when they, in their less specialized position, realize that this patient doesn't have to die today, to stop that patient from dying, they call a perfusionist. And we do the thing that we do. We stop patients from dying. We keep them alive while their heart is stopped. We keep them alive while they're not breathing. Every perfusionist is a specialist, and there is no shame in being a perfusionist that works in larger patients. There is no benefit to being a perfusionist that works in smaller patients. We're here to preserve, to force life into the darkness. Every perfusionist has an elite, exceptional skill set that can be used. We can use plastics and metals and pumps and solutions to replace hearts and lungs. That's ridiculous. Nobody else comes close to that. So why would it be even more special just because you did it on a small patient? So small seems to be an issue here. And you saw my lecture to the students before I got here, in which I explained to them in the most educational terms, small is not special. Consider that maybe small doesn't make a difference. But if we're going to consider that small is special, then let's consider small being special. So what about isolated limb perfusion? It's kind of a reduction from a full-size body down to something a little bit smaller. That sounds special in the definition of special being small. How about myocardial protection? We isolate hearts from the rest of the body and we perfuse that selectively every day on adults and on kids. That sounds pretty special. That's small. This is my favorite. Let's look at selective cerebral perfusion. We can put a full-size adult on bypass with big equipment, and we can pump them fast and hard in the beginning of the case, and then we can switch gears over to with special cannulation technique to use a profound hypothermia, circulatory arrest, modified blood gas strategies, and cerebral oximetry technology. We can use some special drugs here and there. We can keep the brain, perfuse just the brain, way smaller than a baby. That would probably be the ultimate specialty here. Maybe there ought to be a track at our national conference for the selective cerebral perfusionist, the king of all kings, when it comes to this group of commoners. So let's drill down on some of these issues that I think my counterpart here may be a little misled about. So technology. Let's talk about the difference in technology from pediatric to adults. Does it really matter what size car you drive with regard to the licenses and the skill set that you need to have to drive that? So big cars, small cars, gas cars, diesel cars, electric cars, automatically shifting cars, manually shifting cars, self-driving automobiles, 2-cylinder engines, 12-cylinder engines, it doesn't matter. You need one license to drive that. Maybe it's not about the car. Maybe it's about the application of said vehicle, the environment in which you conduct this. So notice that it doesn't matter whether you drive on country roads or throughways or through heavy city traffic or dry roads or on wet roads, or if you're driving through the ice and snow of Syracuse, New York in March. It doesn't matter whether you're driving the daylight or the darkness, you need one license to do that. Doesn't matter if you drive just occasionally every now and then, like my mom, or every single day, like me. One license, same license. There are no driving specialists when it comes to this kind of thing. And I posit there is no driving specialist when it comes to heart-lung machines. Look, they're big, they're small, they're funny shaped. Some of them stand tall, some of them sit down squat. Some of them have the mech systems or miniaturized circuits, some have full-size circuits. This is an entire heart-lung machine that you can pick up and put in the seat next to you in your automobile. One license, one CCP, there's only one specialty. So yeah, your tubing gets a little small, your clamps get a little bit smaller, you have smaller arterial line filters, you have smaller oxygenators. All these things work exactly the same principles. It doesn't matter that it's smaller. We have different monitoring technologies, but it's really the same technology. It's just a different size pad for a different size brain. It's the tool has been reduced to the size of the patient. So I would ask you, are there any special technologies that are unique to the pediatric population? Let's look at skills. How about the skills the pediatric perfusionists use when they're operating their little equipment? So it was suggested that the skill set is distinctly separate. And I would agree that these documents are completely separate, as in there's a document over here with a title on it, and then you can go to another link and download this document that has a different title on it. But have you had the opportunity to flip the pages? They're 98% exactly the same. Only minor little tweaks here and there. The table of contents reads almost exactly the same. It's clear that a larger committee built this document and a pediatric committee took the document and modified it slightly and threw the word pediatric in at the top. And there's nothing wrong with that, because it's true. There's no difference in the skill set. The standards and practice for pediatrics is almost exactly the same as it is for adults. They're not different enough to declare a specialty, I would say. And in fact, we researched this in our department. Mr. Darling published a paper that I would think that he would remember because it proves that he has no case. When you look at these two papers, we surveyed the community. You answered these questions. And we identified what are the skills associated with, we had to use the word adult so that the pediatric people would understand. And then we also asked about the pediatric skills. And we identified a list of skills for adult cardiopulmonary bypass and a list of skills for pediatric cardiopulmonary bypass. And the only difference is that adult perfusionists consider ultrafiltration to just be ultrafiltration. Doesn't matter how you're operating the device, it's using an ultrafilter. But the pediatric community, they want to break that up into 4 different skill sets over here. One of which, by the way, didn't even meet the metric for being qualified as a fundamental skill. So we've identified 22 fundamental skills for operating a heart-lung machine on adults and 24 for pediatrics, but the only difference really is what you call the hemofilter. So from your own opinion, your FPPs told us that your skill set is exactly the same as the adult, just as your committees told us that the standards and guidelines are exactly the same as the adults. What? Oh, I got more time, you're saying? Okay, the light's still green. All right, slower and smaller. I've heard the suggestion that there's an issue with regard to response time and precision. But if you do the math, and math doesn't lie, pediatric perfusion is often slower with longer response time requiring less precision. You like to impress the adults by telling us, oh, my reservoir level is 50 mLs, but your flow is only 300 mLs, so your response time is 10 seconds. Whereas an adult with 250 mLs and a flow of 4.5 liters has 3.3 seconds. That's going to require a lot of precision. So are there any pediatric perfusion skills that are unique to pediatric perfusion? You do it and they don't. That's what I thought. Physiology, let's look at the physiology, adult versus pediatric. And this is, I think, where we get most of the discussion because it's like, oh, Bruce, it's about the babies. They're so cute. And it's true, babies are cute. But how about the physiology of the babies? This is where you think you're going to get some traction on the issue, and you point out the congenital heart defects present with unique physiology and require special corrections and modified perfusion parameters. And they're like, well, the other day I was operating this case and I had like all this volume coming in through my vents. You don't get that in adults. Like, well, it's a reservoir. It's got some inputs in the top, and you got to match what comes in the top with what you draw out the bottom. So in adult heart surgery, what if you went on bypass and it was a redo procedure and they cut the heart and you go on with 2 suckers, and then a little bit later you get one of your venous cannulas, a little bit later you get a second venous cannula. You got volume coming to the top of that reservoir all over the place, and you're perfusing as best you can. This is about measuring your adequacy, evaluating and assessing your adequacy of perfusion. You're not a specialist in vents, drainage. We provide adequate perfusion. Oh, PCO2 management is so different in adults. We've got this little thing that called cerebral steal, where we might not perfuse the brain well because the lungs have a different. Oh, you're looking mean. Molly's giving me the eye. I'm reaching her. So this is all about sweep flow management, and we have technology that works in big people and little people as well with regard to inline monitoring and cerebral oximetry. We manage CO2s in adults to control perfusion to the brain, and you do as well for little patients as well. So that's about the physiology. I would suggest that kind of physiology is what makes the surgeon special, because he has dozens of different procedures that they don't do in adults. They can be special. If they want to call themselves special, that's fine. I don't think that perfusionists are, because there is perfusion related physiology, and that's the exact same formulas. The only thing that might change is the concept you put in based on the weight of the patient, the age of the patient, to identify whatever. Am I going to target 100 or 125 or 150 or 200 mils per kilogram per minute of blood flow? So you do some math. And so I will concede at this point, pediatric perfusionists do more math than adult perfusionists. And you spend more time reading cannula charts. But in 1995, I published my very first professional paper in which I taught a spreadsheet to do all of that for me in about an hour and a half. So if you can teach a spreadsheet to do the thing that makes you special, it ain't that special. The principal difference is variation, I heard. So are you comparing, I wonder, are we comparing the most complicated pediatric cases to the most bread and butter adult cases? Because that wouldn't be a fair comparison. Let's compare your most complicated cases to the adults' most complicated cases as well. Does every pediatric perfusionist do a DHCA with pH stat on Norwood that's under 3 kilogram every week? Or every once in a while you get like an ASD that they didn't close in the cath lab in the last 30 minutes. And it's a pretty straightforward, it'd be like our cabbage times 1. So the most complicated procedures in adults are pretty rivaling. Remember the elephant trunk aortic arch replacement or the frozen section that we talked about in DHCA and selective cerebral perfusion? Come on. No, we don't do, every adult perfusionist doesn't do that every single day either, but make sure we're comparing apples to apples, not your most complicated to our most simple. So I would ask, are you a extracorporeal technologist or a pump tech? Now, the idea difference between a technician and a technologist will have a lot to do with how you view things. And a technician monitors and maintains protocols with predetermined parameters. They told me to turn this up to 150 mils per kilogram, and I did. And oh, today is 150, but yesterday was 125, and these two cases are totally different. But actually, if you were a technologist, you would just say, yesterday I was perfusing adequately, today I'm perfusing adequately. They require 2 different flows to do that, but my big picture item is perfuse the patient adequately, not achieve a certain blood flow at a given time. So if you see the differences here, you're really focusing at a technician level. If you see the similarities, then you're focusing at a technologist level. So it's about the practice of the fundamental skills. So I would ask, is there anything that pediatric perfusionists do that other perfusionists don't do? I was feeling pretty good. So the hallmarks of a medical subspecialty are a validated body of knowledge and a formal educational training process and a certifying body. I would suggest the pediatrics have none of those. And I would end my introduction here so that Mr. Darling can prepare a retort.
He can be very persuasive. He can use cute metaphors like cars, but that is a ridiculous comparison. A Hummer to a small car. That's rubbish. Saying that the technical skills are not different, I disagree with. Yes, we did publish a paper, but apparently your name is on it, but you didn't really read it because this survey suggests that pediatric and adult CPB largely share common fundamental skills. This is not to suggest that adult and pediatric perfusion procedures are the same. The survey did not address physiologic and anatomic differences. And I think that is the difference, Bruce, is it's that synthesis between the technical skill and the physiology and the unique anatomy in the neonates and infants and children that make pediatric perfusion so different. Things can have the same fundamental skills. I'm a racket guy. I like to play tennis. And there are fundamental skills like the backhand in tennis, but those fundamental skills, there's a backhand in table tennis, there's a backhand in pickleball, and they're very similar on paper. They even have some of the same sub-steps, the backswing, the strike point, the follow through, all of those are common, but nobody would argue that these are the same sport. So I think you have to look a few levels deeper, Bruce, and understand that all these cardiac differences that we can see have a direct impact on the interface between our technology and the patient's physiology and the patient's anatomy. You had mentioned those hallmarks. The validated, the body of knowledge has been worked on by the pediatric committee and it's under development. And so I think that's forthcoming. We have other elements in our profession that would suggest that the educational elements are important. We have textbooks devoted to pediatric cardiopulmonary bypass. And if you read those prefaces, they're really interesting on what the surgeons identify as the differences in between cardiopulmonary bypass in children and adults. So we have textbooks. We have every cardiopulmonary bypass book has a chapter on pediatric cardiac surgery. So why do we have textbooks? Why do we have chapters if there's really no difference? It's because there are. Because there is an educational component that we need. Now, I will also concede that we don't have you don't get board certified in pediatric perfusion. And, there's one certification, it's certified clinical perfusionist. But hey, we didn't have that until the 1980s. Yeah, so we have a fairly young career profile. And maybe before the lifetime of these younger perfusionists, there will be some kind of certification process. Right now, we do have recognition. We do have the Fellow of Pediatric Perfusion, and this is the highest distinction a pediatric perfusionist can achieve. And so this is within our professional organization. Again, this suggests the professional community consensus on pediatric perfusion. And your very own graduates, Bruce, are proud members of this group of people that have achieved the FPP, which is a difficult achieving. One other thing before we let Bruce back up here to fill your head with nonsense. The other difference, I think, is there is a mental, psychological, emotional difference out there. When I talked, when I had kids, all of a sudden pediatric perfusion changed for me. I mean, all of a sudden it's like, whoa, wow, there's a parent connected out there. And that's a difference that many adult perfusionists will say, pediatric perfusion is not for me. I don't want to, I don't want to be involved in these high-risk surgeries on young, innocent children. And so I think that's an important component too, that we should throw into the mix here as well in terms of differences. And with that, Bruce.
27 seconds.
Make it quick.
Good thing there's not much to rebut there because there wasn't much there. Remember, let's take a look at these take a look at these chapters, these books that you have about pediatric congenital heart surgery and cardiopulmonary bypass. Let's open that up. Here's the table of contents. Every single one of those chapters is an adult chapter, except for two. You can take the word pediatric off the top, back out those two chapters that talk about defects and perfusion considerations for the defects, and you'd have an adult textbook. ACPE approved curriculum says, so with regard to, is it a specialty? No, in school, we have to teach these things that are, as far as I can tell, the only thing that's different about the body of knowledge for pediatrics. There's vascular embryology, cardiac embryology, congenital heart defects, or cyanotic, obstructive, and miscellaneous defects, and pediatric circuitry, all in the consensus curriculum for perfusion school. There's no special education process. There's only the education process. And everybody that wasn't on the job trained, you had this. And that's how you became a pediatric perfusionist. So bottom line is, if you compare peds and adults on technology, technical skills, physiology, you come up with the fact that adults cover way more things than pediatrics. We're more inclusive in the scope of practice. So is there anything that pediatric perfusionists do that other perfusionists don't do? I will leave you with that today.
Thank you both. So we have just time for maybe two questions. If we, you guys step up to the mic in the middle, if you don't mind, quick, Jeff. Thank you.
Bruce and Ed, both those presentations were hilarious. And I thank you for that. And Bruce, I thank you. I feel so much more special today. That was really good. But I've got to point out that the difference between a chimpanzee and a human is about 1.2% difference in the DNA. And it's a big difference. That's one thing. Another thing, I think we got a problem because we call it pediatric perfusion. Really, it's congenital perfusion. I think what makes us very different is we take care of 800-gram patients all the way up to 2.0 BSA and larger. A big cohort of patients that the adult side just really doesn't take care of. And I ask all the perfusionists in here, many of us work in adult and pediatric centers. And if you ask a pediatric perfusionist if we would go over and do an adult case, most everybody would say, yes, I'd be happy to do that. But if you do the reverse and ask an adult perfusionist to come over and do a Norwood or even an ASD, universally you get a no. So I think that's the big difference here. There is a huge difference. And Ed, thank you very much for your presentation.
I'm pointing out there was no question there.
Hi, I'm Melissa. I'm from New York. I'm an adult perfusionist, but I just wanted to see what your thoughts were on how the STS subcategorizes complexity in pediatric cases and how some centers are tertiary academic medical centers that cover the gambit of cases, and others could be smaller community hospitals that don't cover them and they refer those patients over to a larger center. So what do you think the differences between the minutia and differences between an adult and a pediatric perfusionist versus what role exposure and repetition play in developing competency, especially in emergencies?
So I love it. I took a slide out because I didn't want to go too long. I missed that. But there was a discussion about familiarity versus a specialty, and specialty has to have some things that make it special. And I think I proved beyond a shadow of a doubt that there's nothing that makes it special. But familiarity is what your question is about. And we have, people feel uncomfortable when they have to do things that they haven't done that often. And we showed in our simulation laboratory, however, that you can take experienced people with a skill set, put them into an unfamiliar environment, and their performance will still be at a very high level, but they hate the entire experience. They feel uncomfortable with it, but they have the skill set because they are the specialist that operates this equipment. So it's a matter of familiarity. And I totally understand why hospitals that don't do it a lot send it to places where they do it a lot and they're more familiar with it.
We have time for one more question.
Doug Vincent from Ventraflow. This is a quick question, Professor Searles. In New York State, and I love the analogy of the Hummer versus the Cooper. I thought that was great. To drive a bus or a tractor trailer, do you have to get a special license?
Thank you.
Yes, because the technology is significantly different. They have different brakes and they have different stopping distances, and you need a special
All right,
license to drive a motorcycle as well.
I think we're out of time. Thank you, Bruce and Ed. Appreciate it.
Go.
In a battle as old as time, two great warriors will compete to answer once and for all one of the greatest questions in perfusion history.
Thank you. I'm glad no one had a stroke with all those lights, so thank you. So I'm going to present Kevin Connor. He's been employed as a senior perfusionist at Boston Children's Hospital for over 13 years, and he's performed over 1,400 pediatric and congenital cases as a primary perfusionist. He also has collaborated with many of his esteemed colleagues on several publications with others in development. Please welcome Kevin.
Thank you. Thank you. I'd like to thank AMSEC for inviting me to speak at this conference here today. And my talk's a little bit philosophical, a little bit scientific, but not nearly as much charisma as Bruce and Ed. So my apologies right up front for that. But I'm taking the side of hyperoxia, as you can tell. As been said, I hail from Boston Children's Hospital. I've been asked to justify why using hyperoxia is the favored oxygen management strategy for pediatric and congenital cardiopulmonary bypass. At times, this can be seen as a thorny subject matter, and I don't find it a coincidence that a member of our team at BCH has been asked with defending this technique. So let's get into the rationale behind it all. But before I move on to the next slide here, I'd like to see a show of hands for what range of PaO2s your practice targets on bypass for acyanotic patients. Please keep them up as I decrease the scale. So let's start with greater than 300. 201 to 300. All right, and then 121 to 200. So with those hands up, I'd like to welcome you to Team Hyperoxia. Now to second go at this, I'd like to see a show of hands here who consider themselves working at a hyperoxic center. So I'm lacking there, huh? I must admit it was rather difficult to find a simple table clearly defining the ranges of arterial oxygen tensions relative to oxygenation classification. But for the sake of this argument, this is what I'm using from the page et al. Group referenced above in order to know where we all land for our targets. It's widely accepted that under normal physiologic conditions, oxygen delivery is adequate when normoxic oxygen tensions are met. This includes normothermia with normal hemoglobin levels and normal cardiac output. So why do some of us choose to provide our patients with additional cushion of PaO2 tensions while on cardiopulmonary bypass? So let me see here. In order to best answer this question in the setting that I was hired into, this debate forced me to delve into some of the highly influential publications from Boston Children's that far predated my arrival. So I stepped into this institution with a very novice amount of knowledge about the vast amount of history and investigation-driven basis for which my practice would be based from. So at Boston Children's, we believe that sound practices are shaped by their own internal research, creating a cohesively cogent and contextually consistent approach to each and every case, focusing on reproducibility. In interdisciplinary teams, understanding the modifiable variables that can be identified, investigated, and controlled will then lead to understanding of how each can influence specific outcomes of interest. So consistent practices will lead to predictable outcomes. This last quote here is the final sentence of a publication from 1999 from a series of investigations with the focus of optimizing neurologic outcome of patients requiring cardiopulmonary bypass. And it reads, in our clinical practice, we therefore currently use pure oxygen for all pediatric CPB cases. Since this quote, there has yet to be a study at our institution displacing this approach to oxygenation strategy because clinically speaking, there has yet to be a reason to do so. So these two pillars of hyperoxia strategy are what I'll attempt to establish and describe in order to justify our usage of Boston Children's. First and foremost is maximization of oxygen loading in the tissues, all of them including the myocardium in the face of induced ischemia, i.e. using a cross clamp. Secondly to that is offsetting reduced perfused capillary density in the setting of a non-pulsatile perfusion layered with dilution and imperfect moment-to-moment blood flow oxygen delivery relative to essentially oxygen consumption in all regions of the body. So the focus of this particular paper here was to parse out the impact of hypoxic injury versus that of a reperfusion injury based nature, deciding what level of oxygen tension to run your arterialized blood flow at presents a trade-off or a cost-benefit ratio where collateral damage can and will occur, and applying what this investigative paper ascertained was meant to determine what had to give, whether it was optimizing oxygen delivery to the tissues and preventing hypoxic cell death, or mitigate the known harms of reactive oxygen species production and the havoc they wreak on cell organelles and their function. So pick your poison. So the findings: after 6 hours of reperfusion, brains were fixed and histologically examined. This means that study subjects, that of which were piglets, had to be sacrificed, die, and histologically sectioned. And I hope that we don't do that to our own patients. So an investigation of this granularity has to reveal specifically what was benefited from and sacrifice due to the chosen oxygenation strategy, Normoxia versus Hyperoxia, the exact point of what this debate focuses on. But there's one problem with me using this study to justify the use of hyperoxia, a contextual applicational problem. Problem is it's outdated a bit, isn't it? Seldom do procedures require deep hypothermic circulatory arrest any longer, specifically cerebral arrest. So due to the development of alternative cannulation techniques and strategies, blood flow and therefore oxygen delivery of some quantity can continuously be provided to the brain. Use of any degree of hypothermia would be used to safeguard against any mismatch between oxygen demand and consumption relative to oxygen delivery abilities. Hypothermia would then allow a reduction of systemic flow for improved visualization abilities, especially in the case of extensive, uncontrollable blood return to the heart, specifically patients with high aortopulmonary collateral burdens. There are essentially options to perfuse every region of the body, regardless of surgical needs of the repair. So what advantages does hyperoxia offer any longer that Normoxia can't? Given that our patients on bypass are always in a state of perfect hematocrits, perfect blood flows with corresponding perfect driving pressures, perfect matches of oxygen demand, consumption, therefore delivery. Sense the sarcasm? Now, what really plays out in the OR is here written on the slide here, the conditions that our patients find themselves under. I'm pretty sure that this isn't isolated to my institution here with the second one down on flow. I'm sure we've all been told that in any given moment, which makes us feel like we're lacking a bit, not optimizing the patient. But given that our patients experience some degree of dilution on all pump cases, there you have an example of reduced oxygen delivery when asked to come down on your flow at any given moment. Regional differences often unknown between targeted hypothermic temperatures and therefore potential for oxygen consumption and oxygen delivery mismatches, once again, reduced oxygen delivery. So with all of the technology we have at our disposal this day and age, are we sure that everything is perfect or even back to baseline? If not, does one of the oxygenation strategies offer another layer of safety to compensate for suboptimal delivery episodes to the tissues, the entirety of the patient, every organ and every cell? So here comes in oxygen pressure field theory. First described by August Krogh, a Danish physiologist who was awarded the Nobel Prize in 1929 for describing regulation of capillary flow in tissues. The Krogh cylinder was a theoretical concept explaining the mechanism of gas exchange in the capillary beds. Specifically to skeletal muscle, actually. On this slide are two different scenarios. The first being normal physiology, where the oxygen tension and relative blood flow throughout the capillary are shown to satisfy normal oxygen demands of the tissues. Arterialized blood entering with a PaO2 of 80 millimeters of mercury and exiting the capillary bed, resulting in a venous PO2 of 40, with a blood flow rate of 200 mu per second, which is considered an average velocity. 80% of this diffusion of oxygen was being driven by the vertical radial vectors of the oxygen migration. In the second diagram here, we have a scenario of much reduced blood flow, actually a quarter of the normal conditions described beforehand, yet with an oxygen tension of 500 millimeters of mercury at the arterial end of the capillary. The venous end is only half of the normal conditions scenario with a quarter of the blood flow. In the second scenario, this is what's referred to as the axial kick and is the main source of oxygenating the surrounding tissues in times of much reduced blood flow and what's referred to as, once again, perfuse capillary density. With reduction of perfuse capillary densities, anoxic or lethal corners can develop and not necessarily be identifiable until blood flow is restored to these zones, which would then wash out the resultant acidotic metabolites. So this leads on to the carbon dioxide pressure field theory as well, one and the same. Due to the reduced blood flow here in the second diagram to the right, more carbon dioxide is retained in both the venous end of the capillary and inducing a hypercapnic state in the surrounding tissues with the development of potentially severe metabolic acidosis and normal blood flow rates if normal blood flow rates aren't restored along with normal profiles. On this slide here on the left is a depiction of two differing states of perfuse capillary densities, indicating that when there's an adequate amount of blood flow in the vascular beds, the radius from each perfuse capillary is far shorter than that of the reduced zones, and therefore will be able to continuously supply oxygen demanding tissues with ample amounts of gas exchange. But on the right is a comprehensive illustration of both anoxic and hypercapnic lethal corners that can develop in the face of reduced oxygen delivery, yet with a little help of a hyperoxic axial kick. The development of these harmful zones will be diminished. So I think it's important to realize that when you induce hyperoxia, you also trade off for denitrogenation of the blood. This chart here shows a relationship between steadily increasing arterial oxygen tensions relative to venous PO2s with the resultant surrounding tissue oxygen tensions. At deep hypothermic temperatures, tissues primarily rely on dissolved oxygen in the blood and subsequently the tissues. These values are derived from averaging the PaO2s and simply the venous PO2s. But in this model, the difference between the maximum dissolved gas tension of, let's say, 750 millimeters of mercury and average tissue PO2s would be dissolved biologically in nitrogen tension. With extending the duration of cooling, traditionally at least 20 minutes, the perfusionists will notice ever increasing venous PO2s as metabolism decreases and the surrounding tissues continuously become saturated per se with oxygen. This happening is imperative to lengthening the amount of time where aerobic conditions can be sustained before anaerobic conditions kick in. How do you scroll? Like with the dialogue? Okay. Okay. To go to the end with it first. Which side do you want to be on? So it was back with the chart with the numbers and the diagonal mark on there. I just needed to see more of the actual dialogue section. There you go. All right. So when combined with hypothermia and in the case of cardioplegic arrest, suppressing metabolic demand, one could strongly surmise that these efforts can be seen as a way to mitigate reperfusion injury by reducing the degree of ischemia imparted on any organ, especially the myocardium, so that once blood flow is reintroduced, reactive oxygen species production will be of little clinical significance thanks to the added oxygen saturation of the tissues due to creating hyperoxic conditions. Of note, while we're on the subject, denitrogenation via hyperoxia has been shown to abate GME or gaseous microemboli, damage by off-gassing nitrogen-dense GME from the operative field entrainment, both in the oxygenator and once lodged in the vasculature, by diffusion of oxygen first into the bubble and eventually into the tissue since it's biologically active, unlike inert nitrogen. So during the development of my argument too, this particular slide got the wheels turning. So MET stands for metabolic equivalence and represents oxygen consumption in cc's of oxygen per kilogram per minute. And at a resting state, this value is about 3.5. It can go up to 17.5 during exercise and is actually at 0.7 in the brain at around 18 degrees. So the slopes of each of the 5 different color coded curves indicates the considered safe time of interruption of blood flow and no further oxygen delivery, except for what's dissolved in the blood and tissues for the brain to consume until a state of anaerobic metabolism kicks in. So in the case of protected hypothermic cardioplegic arrest, where the heart's metabolic demand is suppressed by a combination of components specific to each cardioplegia formula, once again, hyperoxia must impart the same protective benefits to the myocardium as what was found in the BCH investigations for optimizing brain neuroprotection. So the question is, gone are the days of circulatory arrest? Well, as it applies to the brain, I certainly hope so. But there's one particular organ of interest that's the centerpiece of our profession that tends to get its unfair share of circulation over the course of many of our cases. That's the heart. The heart wants what it wants, and often that's just oxygen, actually, I'd say. So now let me pass the mic to my esteemed colleague, Nikki Michaud of Monroe Carl Jr. Children's Hospital at Vanderbilt, to give her side of the argument why Normoxia should be considered as the optimum oxygenation strategy for bypass.
I'd like to welcome Nikki Michaud. She is the Chief Pediatric Perfusionist at Monroe Carl Jr. Children's Hospital at Vanderbilt. During her career, she has spent time in research and education. Her interests include quality improvement projects to promote interdisciplinary team collaboration, as well as simulation. She participates in annual simulation training of the cardiac surgery fellows at Vanderbilt, as well as with the STS.
Hi. So I'm Nicole Michaud, and thank you for the invitation to speak and being tasked with Normoxia, and which is better in our patient management of oxygenation in both the acyanotic patient population as well as a cyanotic patient population. I have no financial disclosures on this material. I thought it would first be nice to get this debate off with a little bit of comparing and contrasting between the two cities, Boston and Nashville. Compare and contrast the two cities, Boston and Nashville. When we visit cities, we all want to take in the food. And so if you go to Boston, you're going to take some baked beans in. I'm not sure about y'all, but that's not my favorite food. If you come to Nashville, you're going to take in some Nashville hot chicken. And correct me if I'm wrong, Ron, but last night on that buffet, there were baked beans, but it didn't say Boston baked beans. But the hot chicken, it did say Nashville hot chicken. If you go, you want to visit, oh yeah, well, so I win the food, okay? Boston is well known for the Boston Marathon, but you got to qualify. And I got it on my bucket list, so you're going to get me in?
Got high standards.
Otherwise, I'm going to have to do the Nashville Marathon. When you visit, you also want to visit some iconic places. Boston's got Fenway and the big green monster. I want to visit that too. But Nashville's got the Grand Ole Opry and the Red Barn, and I think those are on people's bucket list as well. And finally, we all like those beverages. We like to visit them. Boston has this place called Cheers. Does it have a rooftop? Can you drink on the rooftop? Yeah. Nashville's got this place called Old Red. You can drink on that rooftop. But you can drink inside Cheers, right? Yeah, but you'll see this guy. You come to Nashville and you're drinking Old Red, you'll see this guy. Hands down, I win. So the objectives are reviewing the physiology of oxygenation and describing reperfusion injury, and then just kind of review the literature on Normoxia. So oxygenation of tissues is one of the most important processes that occur in the human body. Oxygen is the third most abundant element in the universe after hydrogen and helium. Without properly oxygenation of the tissues, metabolic processes cannot function efficiently and effectively. We have cellular functions that are then altered. Gases are added to the atmosphere and removed, and it is known that hyperoxia occurs when a partial pressure of oxygen in the breathing environment is greater than that which is found on the Earth's atmosphere at sea level. Boston sea level? What is hyperoxia and what can it cause? So hyperoxia is a state of excessive supply of oxygen in the tissues and organs. Dissolved oxygen does not increase oxygen transport. It is a result of continuous exposure of super physiological concentrations of oxygen. The result of this is excessive supply of oxygen, resulting in a large influx of oxygen reactive species. So reperfusion injury can occur, and this results in an increase in cellular injury. This process can result in 3 stages: production of oxygen-free radicals or reactive oxygen species, inflammation, and influx of calcium. So what is reperfusion injury? Hyperoxia has been shown to extend and accelerate damage that occurs during ischemia. This reperfusion injury occurs at the onset of reperfusion, occurring at the onset of the elimination of the ischemic condition with reestablishment of flow and oxygen delivery. When oxygen is reintroduced to the ischemic area, reperfusion can be reversible or irreversible, and it depends on conditions of that state. So reactive oxygen species are derived from oxygen-free radicals produced during mitochondrial respiration through incomplete reduction of oxygen. Free radicals are chemical species that have a single unpaired electron in the outer orbit. The production of what is called toxic oxygen species is proportional to the PO2. The chemically reactive molecules known as radicals or unstable oxygen molecules are derived from oxygen. Normal metabolism does lead to cell production or cell protection from oxygen-derived free radicals by what is known as endogenous free radical scavengers, antioxidants. They chemically react with an unpaired electron through electron donation, which forms a stable electron pair and neutralizes the free radical. During conditions of stress or hypoxia or ischemia, these antioxidants can be depleted. And therefore, when reperfusion occurs with hyperoxia, the antioxidants are not able to neutralize the free radicals. In the end, this results in a higher production of free radical production. Oxidative stress occurs with this production of reactive oxygen species. Increasing this and not having that scavenging system is ineffective, and this is known as oxidative stress, resulting in a lot of free radicals that are unopposed by endogenous antioxidants. This is one area that I'm very interested in pediatrics, because we don't have a lot to combat that inflammatory mediator response that occurs. And oxidative stress is part of the inflammatory response and is an amplifier of this process. It is well known that cardiopulmonary bypass also influence the inflammatory response through various processes in the ways that are biomaterial factors as well as biomaterial independent factors. It is known that neutrophils are a source of reactive oxygen species. The ability to reduce the impact of cardiopulmonary bypass induced inflammatory response is an aspect of management that is continuously being researched and evaluated as how we can reduce that effect in cardiopulmonary bypass. So perhaps through Normoxia management, we are able to reduce the amplification of this process by the reduction of oxidative stress that is created through hyperoxia. And so I'd like to share this paper with pagan colleagues that they wanted to investigate if after hypoxia or ischemia, whether normoxia reperfusion would be associated with less inflammation, myocardial injury, and oxidative stress. What they did is they placed 2.9 to 3.3 kilo rabbits on bypass, and then following cardioplegic arrest and aortic cross clamp of the hearts, they reperfused the rabbits with normoxic conditions, which was 21% FiO2, or hyperoxic conditions of 100% FiO2. In their population, which was 6 and 7 rabbits, they found that interleukin and C-reactive protein, which are plasma markers of inflammation, were reduced, and they found statistical significance in the reduction of C-reactive protein at 30 minutes after reperfusion, and statistical significance in interleukin 6 at 120 minutes after reperfusion. So this would indicate that hyperoxia should be avoided to aid in the reduction of inflammatory process occurring as a result of reactive oxygen species. So what about defense? How can we defend against oxygen free radicals or the reactive oxygen species? So we know that under normal conditions, we have these endogenous antitoxins that will react. And so we need to make sure that we maintain that balance within our management of cardiopulmonary bypass. And one antioxidant that I'm very interested in and would love to hear if anybody is using it is vitamin C. We're actually giving vitamin C to all of our patients prior to ventricular assist implantation and then through transplantation. And so we're using that as an endogenous antioxidant. And there's some good literature in the adult population. Again, we're specialized, but. What about the cardiovascular effects of hyperoxia? Hyperoxia induces vasoconstriction, and this has been illustrated in the brain, heart, and skeletal muscle. Hyperoxia exerts direct effects on the blood vessel, and therefore increased reactive oxygen species may directly affect the vascular smooth muscle by closure of the ATP-dependent potassium channels. The reactive oxygen species affect vascular tone in the endothelium, with an increase of endothelium and decrease in nitric oxide and prostacyclin. One thing to note is all of our neonate acyanotic or cyanotic patients, they're Norwoods that have low ventricular function. We are potentially creating an afterload situation for these patients. Due to vasoconstriction on blood pressure, increases cardiac parasympathetic responses, leading to a decrease in heart rate and contractility, resulting in a decrease in cardiac index. Again, this is not a situation that we really want to set up in our patient population. So reactive oxygen species can also induce intercellular calcium overload due to modifications of the sarcoplastic reticular calcium and can impair diastolic dysfunction. What about transition from fetal circulation? At birth, it's interesting to note that during transition from fetal to neonatal life, which has been found to be a very critical time for maintaining that balance of production of free radicals and the antioxidant production in the newborns. During this period, what has been found is that there's been a 15% increase in the native production of antioxidants to allow this change from a PO2 of 20 to 25 millimeters of mercury intrauterine to 100 millimeters of mercury outside. So it's a very it's a protective effect that is native to the neonate. What about the optimal PO2 on cardiopulmonary bypass? So there recently was an article published in the Journal of Vascular and Anesthesiology in 2022 of August, and they shared the results of a national survey sent out by Harvard Medical School in Boston, which they invited 3,335 anesthesiologists and perfusionists to participate in this survey. They received about a 14% return rate, and they had 237 perfusionists return the survey and 317 anesthesiologists. The perfusionists in this survey were not categorized into a pediatric specialty or an adult specialty. The perfusionist that participated reported a target range of arterial PO2 on bypass of 150 to 325 millimeters of mercury, with too low of a PO2 on bypass being 100 millimeters of mercury and too high of a PO2 being 375. So really, you can see there's a variety of managements of PO2 that we see in the management of cardiopulmonary bypass. So what does the literature reflect? This is a nice article. It's an adult article. So in 2021, it was a randomized double-blind study conducted on patients that were 65 years or older, having coronary artery bypass surgery. They were cooled to 32 degrees. The trial had two arms, a normoxic arm and a hyperoxic arm. They looked at the neurocognitive function at day 2, 1 month, 3 months, and 6 days following surgery. They demonstrated that the titration of intraoperative oxygenation resulted in no significant difference in postoperative cognitive function after cardiac surgery. This data would suggest that normoxic oxygen strategy can safely be employed without impairing postoperative neurocognitive function. And so what they did is so we saw from that Boston study that anesthesiologists view, and I didn't give that data, but anesthesiologists view normoxia a little bit different than perfusion. And so in this study, they looked prior to going on bypass, they had PO2s of 70 millimeters of mercury or saturations greater than 92%. Once they went on bypass, they managed those patients' PO2s basically by a PO2 of 100 to 150. And then their hyperoxic arm was everyone was 100% FiO2 before surgery, as well as on cardiopulmonary bypass. This is a nice study also out of 2014. And what the authors did is they took 376 patients that were having tetralogy of flow repairs. They did, and you can see they did subclass the patients, and they found no statistical significance in the subclass, I will tell you that. But they did find statistical significance when they looked at the overall pool of patients in the association that higher PO2s during aortic cross-clamp occlusion did independently increase the myocardial dysfunction risk factor after bypass. And so they had two groups here where they defined their hyperoxic group as 250 millimeters of mercury and their normoxic as less than 250. It was a retrospective study. So one thing that I liked that they did is they went through their data and they found this point, and they used the highest PO2 during aortic occlusion, and that's where they did decipher between normoxia and hyperoxia. So again, Pagan colleagues used a rabbit model to look at reperfusion with hyperoxia and normoxia. They were able to show through two studies that cardiopulmonary bypass with cardioplegic arrest would be beneficial to be managed with what they called controlled reperfusion or oxygenation. And they measured biomarkers that suggested that myocardial, renal, and neurological dysfunction and injury are a result of oxidative stress and inflammation, as well as apoptosis, leading to a higher incidence of oxygen-free radical production with hyperoxia. Morta published this research using a neonatal pig model of acute hypoxia, where he looked at the effects of initial reoxygenation. So if you look at the first graph here, what they did is they had created a model, a neonatal pig model that was hypoxic. And they had a pig model that was not subject to any hypoxia, and they used blood cardioplegia, and they wanted to look at the percentage of recovery of LV function with initiation of cardiopulmonary bypass. So the darker three squares or columns, what you see there is what the PO2 was at initiation of cardiopulmonary bypass. And so what they found in this study was that they were able to see that the PO2 values reflected during the initiation of bypass did have an inverse relationship to the recovery of LV function post cardiac bypass, meaning that going on with a lower PO2 was more beneficial to the hypoxic myocardium. The middle middle one there is where they took their acyanotic and cyanotic patient population, and they looked at MDH, which is an oxidative stress biomarker. And what they wanted to see is if there was any kind of reserve, antioxidant reserve between the two patients. And you can see that in the acyanotic patient, there was antioxidant reserve, where in the cyanotic patient, there was no antioxidant reserve, which is representative of the MDA going high. The last thing that they did in their study was looking at serum troponin during hypoxic cardiac bypass. And again, they had acyanotic patients and cyanotic patients. And you can see there that definitely the cyanotic patients all trended in the direction of higher troponin levels post cardiopulmonary bypass with hyperoxic management. I can go to my conclusion. That's good. So overall, oxygen has indications, contraindications, risks, and benefits, just like any other drug. Superphysiological levels are known to induce oxidative stress, production of reactive oxygen species, which has shown to increase the tissue damage and result in poor outcomes when reoxygenation of ischemic tissue is managed with hyperoxia. The literature is pretty variable in the definition of what is normoxia and what is hyperoxia. So it would be very valid scientific research to have a large randomized trial looking at specific levels of normoxia and hyperoxia. With the advent of technology, the ability to continuously capture and monitor PO2 levels has been a standard of care in cardiopulmonary bypass and is readily available to all perfusionists. It can be argued that based on temperature management, a cyanotic patient may benefit from the utilization of normoxia or a controlled gradual reoxygenation for myocardium, renal, and cerebral protection. I think in reviewing the literature, the question may not be which is better, but rather when we are managing our patients in the morning, picking out what oxygenation management strategy matches their physiological state as well as the procedure that's being done.
And now back to Kevin for the rebuttal.
So. All right. I'd like to start out by saying, so what? Let's get back to how to prevent anoxic cell death. So what can be extrapolated from our deep investigations of optimizing neurological protection, anything whatsoever, it seems as though the combination of using pH stat to suppress metabolic function relative to alpha stat, along with this rightward shift of the oxygen dissociation curve of hemoglobin, layered with minimizing the dissolved amount of, or maximizing, sorry, the dissolved amount of oxygen in the blood throughout denitrogenation, resulted in the best possible outcomes for the time. Nowadays, that can be now that we can sustain blood flow to most regions of the body, cardioplegic arrest of the heart is often unavoidable. Instead of focusing on the many harms of reperfusion injury upon reintroducing blood flow to an ischemic heart, should we consider how possibly hyperoxia of both the circulating blood volume upon initiation, along with oxygen tension of the cardioplegic solution, can possibly lengthen the amount of time of aerobic metabolism before anaerobic conditions kick in and prime the conditions to catalyze the degree of reperfusion injury. We all must come to terms with the notion that reperfusion injury is an unavoidable consequence of cross-clamping and is an inconvenient truth of most bypass runs. So what does our multi-layered approach at Boston Children's try to accomplish? So when you stack all three of these together, hyperoxia, pH stat, and hypothermia, this creates an extracellular milieu of acidosis, so more hydrogen ions inside of the cell, which suppresses metabolic activity relative to alpha stat in combination with hypothermia by creating intracellular dormancy. Therefore, you have lower membrane permeability, reduced calcium influx upon reperfusion, and the mitigation of unavoidable reperfusion injury. So lower relative oxygen consumption while maximizing oxygen unloading from the hemoglobin with a rightward shift of the oxygen dissociation curve. And all along in the background, hyperoxia served the purpose of increasing oxygen delivery, availability, and sustainability when hypoxic conditions arise, possibly unknowingly. So does reperfusion injury occur? We believe that hyperoxia gives the perfusionist and our patients a cushion of additional oxygen availability in unforeseen instances of reduced flow and therefore oxygen delivery. The OR environment is so dynamic that we believe that this must be baked into our practice, even in the case of anesthetic care. Often our patients are ventilated using hyperoxia to buy us time and act as a reserve during intubation before any signs of decompensation occur when difficulties unexpectedly arise. I think it's vital to mention that what's highlighted in the red here, often forgotten, are antioxidants, as mentioned by Nikki. They act as a natural regulator in instances of oxidative stress and bring everything back into balance. So notice that we know that intracellular pH, when it's risen, well, elevated above 7.2, that those antioxidants come back online and are restored in their functionality. So for us at Boston Children's, we see the value of hyperoxia being the most benefit in these two main instances as mentioned beforehand. Increasing and maximizing oxygen loading the tissues, and second to that is offsetting the reduced perfused capillary density in those settings where you're told to turn down your flow or anything that would vary from baseline. So let's take a different angle of hyperoxia itself. So this particular paper from 2020, along with numerous others pertaining to the topic of preconditioning the myocardium before ischemic insult, focuses on how either method, hypoxic or hyperoxic, or in combination, can affect endothelial function in zones of reperfusion after induced ischemia. So here in the study, there are 32 rabbits, it was the model, split into 4 groups: hypoxic, hyperoxic, a combination of hypoxic and hyperoxic preconditioning, and the control group. They were respectively preconditioned while on ventilator, pre-bypass, and after initiation, induced 45 minutes of ischemia to the left main by direct ligation, and then reperfused for 2 hours on bypass. Under the 4 pre-ischemic conditions, levels of endothelial 1 expression, which is a reflexive vasoconstrictor, along with nitric oxide production, the vasodilator molecule that we know of, were measured. And after 20 minutes of preconditioning in each group with a 10-minute split for the hypoxic hyperoxic cohort, it was found that this particular group best maintained endothelial function with a physiologic balance of the production of both metabolites, endothelial 1 and nitric oxide, and therefore allowed the myocardial endothelium to maintain its inherent modulatory abilities. And now for a few perspective flipping quotes from a rather deep and scientific investigation here into the former explained mechanisms. So I'll read these, and it's pretty interesting to take on these. Hypoxia or hyperoxia could be such a stimulus that will induce myocardial endogenous protective properties. ROS generated by different types of preconditioning and postconditioning are known to act as triggers for myocardial protection. Endothelial 1 is also responsible for the positive inotropic effects of angiotensin II via the production of reactive oxygen species, and hyperoxic preconditioning leads to increase of ROS in the blood, thereby triggering protective processes in the body. So concepts that were once taught that are completely detrimental, on the contrary, now show properties of working synergistically as the whole system. So now I pass this back off to Nikki.
How many people here do circ arrest in pediatrics? How many do antegrade cerebral perfusion during that time? Oh, can I go back? So hyperoxia, useful or not? So normal conditions, 98% of oxygen in blood is bound to hemoglobin, increasing that oxygen concentration by creating environments which the arterial PO2 is super physiological levels. Again, this is leading to oxygen-free radicals. We know that during cardiopulmonary bypass, there is a need to reduce flow, which leads to the thought process of the need to maintaining oxygen delivery with elevated PO2s. But technically, we don't get any more delivery. Hyperoxia is known to lead to an increase in systemic and coronary vascular resistance, which leads to impairing cardiac diastolic function. We need our cardiac diastolic function post cardiopulmonary bypass. There is literature that's suggesting that hyperoxia does provide preconditioning of the myocardium to tolerate the period of ischemia. But that does result in myocardial arrest, which we do arrest the patients. And therefore, we're arresting them at certain levels with oxygenated blood in hopes of not converting them to anaerobic metabolism at that time. There is plenty of literature, which we didn't get into, that describes the benefits of hyperoxia in the reduction of wound infection. Interestingly, there is a very recent evidence where there's finding that there is an association of 44% increase in odds of death with every 100 millimeters of mercury change in PO2 over normal levels with patients during cardiac arrest and and CPR. Finally, CPB oxygen management. You know, hyperoxia can avoid the potential side effects of cardiopulmonary bypass. You know, oxygen delivery, is it really more bang for your buck unless you're going circ arrest and using the theory? The lack of inline real-time blood gas analysts, we don't have that any longer, so we can know exactly what our PO2 is. What about reduction in gaseous embolization? If you read his first paper that he presented, it will show you that Jonas told you that that actually no longer occurs because we don't use bubble oxygenators. So benefits, there is potentially, you could argue, an improvement in tissue oxygenation at low crit levels and low temperatures. Potentially can increase oxygen delivery, you know, a little bit, 2%. Reduce the need for transfusion, maybe, but there's a lot of costs there. Vasoconstriction, alterations in microcirculation, that oxidative stress, and the increase in inflammatory response. And that's all that I have.
Thank you both. We have time for one question. If anyone in the audience has any.
Great presentations. I enjoyed it. I'm an old-time perfusionist. I was with Aristotle's. I was going to talk about back then, but I was a perfusionist at Tufts Doing Medical Center. I did adults and peds, and we had this problem back there. This is back in the mid-70s, and we were doing children, and we had bubble oxygenators, and a lot of people weren't using bubble trap filters. And I just happened to come across, you know, there's two parts of medicine that are like railroad tracks, and they never cross. But anyways, I picked up this magazine. I'm reading this ophthalmology magazine. It's talking about how high oxygen tension can cause blindness in children. So, and I'm thinking at the time, I'm trying to, back then we had a lot of trouble with bubble oxygenators and over oxygenating. And that's when we started using the inline arterial bubble trap filters, because it would catch a lot of those bubbles, you know, going into the systems. And there's a lot of problems with post-pump syndrome at that time. So anyways, I was, I got this thing, and I have an oxygenator that, it was a pediatric oxygenator. Back in those days, they made it only for adults, baby. You know, they didn't really put a lot of money into pediatric perfusion. Okay, so anyways, the oxygenator that I had, in the manufacturer's recommendation, you could, you know, you needed at least a liter of oxygen flow through it, so it wouldn't plug up the oxygen disparager plate on the bottom of the oxygenator. So anyways, I'm trying to get the oxygen down in the, you know, during the cases. But now I'm dealing with, I did it for the bubbles, and then I'm trying to get the oxygen tension was, you know, 600 to 700 in these little babies. And I read this paper. So I said, well, let's try something different. So I went to manufacturing, and I made up some special gas gauges, which would flow 50 cc's and another one with 100 cc's, 250, you know, 500, and I could switch them off the pump. I made a plate. And so depending on the patient and the size, I could pump in, and I actually lowered the pressure down without clogging that disparager plate. So now, back then, I'm thinking, I'm trying to lower this oxygen tension. It was like, what's all this oxygen gonna do? It's, in other words, there's no benefit to having oxygen that high in a child, and it was the equipment that we were using at the time, But anyways, I'm getting old. I wrote a paper on this in I was published in the JEC, maybe 80 or 81, describing what I did. I'm too old now to repeat it all, but just wanted to mention how it was way back then, and it's still going on today.
Thank you so very much. Thank you to all our speakers. This was a wonderful session. We're going to have a really short break. We ask everyone come back at 3:05, and coffee is in the exhibit hall if you need it. Thank you.